First of all, welcome to everybody who's joined this panel discussion on this important topic on fire safety in Indian healthcare organizations. We are all from Beyond Carlton, myself and Cheryl. Cheryl is the CEO. I'm one of the trustees of Beyond Carlton. We are focused on having fire safety dialogues. A little bit about Beyond Carlton before I get to the panel. Beyond Carlton came out of a fire accident in Bangalore, which happened actually almost 15 years back on 23rd February 2010. And 9 people lost their lives that day. Our managing trustee, Uday Vijayan, lost his son in that fire accident and converted his grief into a movement. And he started Beyond Carlton by bringing in relatives and survivors of that fire tragedy together to form a movement to kind of create awareness around fire safety. So we are today India's probably the only citizen-led fire safety movement. And we're trying to bring in change in the way India looks at fire safety. That's our focus. We do these sessions in different areas. One of the things that we are most concerned about is public spaces. We think that public spaces should be safe. When somebody goes to a public space like a restaurant or a hotel or a hospital or a mall, we all expect safety to be there. We don't want any, and if a fire happens, it's really tragic. So our focus is to bring in awareness, to do advocacy in terms of regulations, and to ensure that fire safety is on top of people's minds. So that's really what Beyond Carlton's focus is. And I'm really glad to have a great panel today to talk about fire safety in a very, very important area, which is hospitals. And I'll quickly introduce the panelists. We have a great set of panelists today. I'll start with Raj. Raj, maybe you can raise your hand so that everybody knows. So Raj has been a healthcare professional for many, many years and has run healthcare organizations. Today, over the last several years, he's founded one of India's leading senior elder care organization. It's called KITES, and he's the co-founder and CEO of KITES. He's also the CEO of Columbia Communities, which is retirement homes. So Raj has a lot of experience on running healthcare centers, specifically focused on senior citizens. So we're really glad to have Raj here today and have him give us perspective. So that's Raj for us. The second person we have on the panel is Arnab. Arnab, raise your hands, please, so that everybody knows. So Arnab is, again, a professional in the healthcare industry for a very long time. He's, again, run hospitals, smaller hospitals, larger hospitals. Today, he's part of the leadership of Manipal Hospitals Group. He is one of the senior leaders there, and he runs the Manipal Whitefield Hospital cluster. So he's, again, got a lot of experience in hospital management. He understands what it takes to run, whether it's a small hospital or a large hospital, the patient flows, and what all goes into running a hospital. So we are really great to have Arnab here to give us perspective. The third panelist we have is Sujayanti. Hi, Sujayanti. Raise your hands, please. Yeah. So Sujayanti is an architect. So it's really good to have an architect in the panel because she'll bring in a very different perspective. So she's an architect and, of course, focused on healthcare. She has maybe over 25 years of experience in building healthcare spaces, designing healthcare spaces, and not just in India, but outside of India. So she's worked in the US, she's worked in Africa. So she understands how do you design healthcare facilities, taking fire safety into account. And she's a patient advocate. So it'll be great. It's really good to have Sujayanti's perspective on this topic. The fourth panelist who's going to join us in a few minutes, and after she joins, I'll introduce herself. Her name is Dr. Lallu Joseph. She's from CMC Vellore. And she also happens to be the Secretary General of a hospital group focused on quality called CAHO. So she's a quality person and focused on fire safety. So as soon as
she's here.
Oh, she's here, Dr. Lallu?
Yeah, she's here. She's right here.
Oh,
yeah.
Okay, great. I thought you were joining a bit late. So yeah, please raise your hands, Dr. Lallu. Yes. So we're glad to have Dr. Lallu again. She's again a lot of experience in the healthcare system. She works for one of the finest hospitals in the country today, CMC Vellore. And but more importantly, she's Secretary General of CAHO, and which is focused on quality, patient advocacy. So safety is something which is really important for the organization, and they're trying to bring about that change in India. And so it's really great to have her perspective. So we have a great panel. So let me kick it off. I'll just take 5 minutes to talk about what's going on the hospital and healthcare organization side, and then I'm going to get the panelists to talk. So let me just share a couple of points. One is that hospitals, we all know, are very complex environments because you have patients, you have sensitive equipment, you have hazardous materials. So all of them, so it's a complex environment, and it's very easy to get a fire started and an accident to happen. There are lots of regulations, there are lots of guidelines, quality procedures, but there have been a lot of hospital fires in India, which highlight the fact that there is poor adherence to safety protocols. And case studies that we have tracked have shown patterns of negligence leading to preventable death. So that's one of the things. The other interesting thing about hospital fires, which one of the fire services head of Delhi, Atul Garg, pointed out, was that not only are you fighting a fire when a fire happens in a hospital, but the fire department personnel also need to respond to evacuate patients. So that causes more complexity. So it's not just one, it's a complex area for a fire to start, but once a fire starts, to respond is not easy. So ideally, we want to prevent fires to happen. That's really our goal. Now, this is something that Beyond Carlton has been tracking. What we did was just the last 4 years. We didn't even go beyond that. We looked at what hospital fires happened in India, where the fatalities were more than 5 patients. And you can see almost 150 people have died in hospital fires. The most recent one, of course, that all of you have read in the newspapers was in Dindigul, where there was a hospital fire in Tamil Nadu. Before that, in Jhansi, we had a big hospital fire. Before that, in Delhi, which was in May, at which a lot of babies died in the NICU, as you all might remember. These were just 3 accidents that happened in 2024. And then, as you can see, there have been a lot of fatalities in different areas, whether it's in Bharuch, which was a hospital fire which happened in Patel Welfare Hospital. There was a hospital fire in Virar, which was Vijay Vallabh Hospital. There was a hospital fire in Vijayawada, which happened. So it's where we've seen several people who have lost their lives. And these fires that I've shown here are not even fires where the fatalities were below 5. So there were several other fatalities which I have not put in this list. One interesting thing that we've seen here is a lot of fires are because of electrical short circuit, which is very interesting. In fact, we have a slide here. There was a study done by a group of academics looking at failures in fire accidents in hospitals in India since 2010. And they found that 85% of the fires happened because of short circuits, 5% because of flammable materials, and a couple of percentage because of other reasons. So very, very telling that short circuits and electricity causes so many hospital fires. So some of the common causes of hospital fires, which we've kind of been looking at, is overloaded electrical systems. The hospitals, as all the people in this call will tell us, they use equipment which is a lot of medical equipment. So some of them can be used beyond its capacity, and during peak periods, especially overworked ACs can cause accidents. Vijay Vallabh Hospital fire in Maharashtra was because of a spark in an overworked AC. There's been neglect in equipment maintenance. So if the electrical systems are not maintained, that can cause fire. This is what happened in the New Life Hospital fire because there was an unsupervised overheating generator. Improper use of oxygen. As we all know, hospitals, there's a lot of oxygen which is stored. So if there's no good handling, it can lead to fires. That's exactly what happened in the Delhi baby hospital fire. Oxygen cylinders were not stored properly. Temporary permission during crisis. During COVID, we saw a lot of fires because, and as a country, we were forced to set up a lot of temporary hospitals. And the one which happened in Mumbai in a mall, Sunrise Hospital fire, they did not have sprinklers, which led to the deaths which happened there. There's obviously lack of emergency protocols and staff training in several places, which can lead to fires. This is what happened in the Ahmednagar Civil Hospital fire. Because their staff, they were not trained to handle the firefighting equipment. There was, failure to follow basic fire safety protocols. This is what happened in Vijayawada Hospital in Maharashtra. In Maharashtra, by the way, all hospitals are supposed to have functional sprinklers, and though it is a requirement, this particular hospital did not have it, so they didn't follow the protocols. And there's obviously weak oversight and enforcement. We all know that there's a lot of delayed judicial processes, legal cases in hospitals can take a long time. So there's a lot of media attention when a fire happens, and then nothing happens for a long period of time. There's prosecution delays, which happens in government hospitals, and a lot of unauthorized construction gets regularized, which again, NOCs are given, which can cause issues later on. That's what happened, for example, in the Shrey Hospital fire in Gujarat. It was an unauthorized construction, and it could have, because it was given approval, that's what happened there. Some of the in COVID specifically, and why I'm mentioning COVID is a lot of fires happened during COVID, but similarly, there could be another crisis wherein we need to have temporary structures. When a temporary structure happens and you don't take care of safety standards, there is a fire that can potentially happen, and that's what happened. Patel Welfare Society in Gujarat, and of course, if there is an overcrowding where because of a crisis, it can result in a fire, right? That's what happened in Madhya Pradesh. So the guidelines are there. I'm not going to go into the guidelines in detail, but in both NABH and Ministry of Health, they've all come up with very detailed guidelines on what hospitals and healthcare organizations need to do, whether it's in terms of the firefighting equipment. Apart from the standard ones which are required, there's specific ones for hospitals that need to be done. So it's very clear what kinds of firefighting equipment are required in healthcare organizations. Electrical is a very, very big thing, and I think we not just in hospitals, in many areas this is ignored. A lot of fires get started because of electrical reasons. So whether it's audits, whether it's figuring out whether in the electrical ducts what kind of material is used, avoiding overheating, all these are critical things in electrical. Oxygen safety is a specific thing for hospitals. So we need to really take care of that as to how to keep that safe. There's a lot of combustible material that are used in hospitals and healthcare organizations. So how do we take care of that is something that needs to be done. Staff training and drills. Good hospitals always ensure there's continuous training that happens and drills that happens. So that's something which is a must. We should need to have detailed evacuation plans. So a lot of once an accident happens, how do you evacuate patients? That's a critical thing. And many lives which are lost because of that, right? There were not good evacuation plans. So that was another case that happened. And of course, regulatory, there are rules. Like I said, you need to follow the National Building Code for new buildings. You need to, have NOCs periodically obtained. So there are all these things which are there, which we don't necessarily follow. So in our view, and we'll get the panel to talk more, we need to have comprehensive fire audits. You need to obviously, stop loopholes from happening. We need to have regulations for facilities as well, temporary facilities, and specifically for pediatric facilities. We need to really see what we can do, because a lot of babies lost their lives in the fires in the last 3-4 years that I talked about. So I will now turn it over to the panel. Like I just introduced the panelists. We have a great set of panelists. And so what we will do is request each of the panelists to talk a minute from their perspective, as talk a little bit about what their setup is and how they consider fire safety there. And then I'll get into some detailed questions. So I'll start with Raj. Raj, why don't you give your perspective and introduce a little bit more about what KITES is all about?
Good evening, Gopal and fellow panelists. Thank you so much for this opportunity. Very interesting topic, and it's actually very sort of very provoking one, because sometimes we, as entrepreneurs and business owners, tend to ignore certain areas. But I think this is something very, very important, relevant. Thanks for bringing it to the fore, Gopal. My name is Rajagopal. I actually head an organization which delivers medical care outside hospital for seniors and elderly in India, in the brand name of Kite Senior Care. We also provide retirement homes and senior living facilities under the brand of Columbia Pacific Communities, otherwise called Serene Communities. Uh, just to give you a little bit more information about what we do, from out of hospital care, we run care homes. And both care homes and senior living facilities are new age business, which I'll talk a little bit more. Uh, our care homes are typically neighborhood models of 50, 60 bedded centers, a typical medical care facility, a step down care facility. And we provide transitional care, which is post operative or post hospitalization rehabilitative care. We provide palliative care and hospice as well in those facilities. And of course, finally, we also manage persons with dementia. Those are the three areas that we specialize under KITES. And we run step-down care centers, which becomes very relevant in the context of what we are talking today. On the other end of the spectrum is where we manage retirement homes, where we provide apartments and villas, a community. We build communities for active aging purposes, and we bring in healthy and active seniors to move in and live as a community where the focus is more on active aging, well-being, safety, and etc. These are the two environments that we manage. As we speak now, we are present in over 6 cities in south of India. From a kites perspective, we have about in 4 cities, we have around six facilities with about 450 beds under our management, going towards 1,000 bed as a ultimate objective. From a retirement home perspective, we currently manage around 1,740 apartments and villas with about 2,500 active seniors living in over there, with another 3,000 under construction in different stages. This is what we actually do, and therefore, when you spoke about newborn and their safety, Gopal, I think it's equally important to look at the other spectrum, which is geriatric, not only just pediatric or the newborn. So they are also equally vulnerable lot, especially with seniors when they become much more older, frailer, and frailty and fragility sets in. Basically, their mobility restrictions, etc., cause a lot of concern, and we need to be prepared about it. So, briefly, just even before I talk about a little bit on that, another 1 minute, it's coincidental that I spoke to you, Gopal, yesterday, and then there was a fire accident in what is called as a nursing home in Serbia. What the business that we are in is also called as nursing home, hospice, and memory care centers across the world. There was a fire accident in Serbia in which we lost 8 precious lives of seniors. There were about 40 inmates over there. Very sad. So I think it's very important to talk about this. I'll take 2 minutes to just briefly talk about what we look at from a fire safety perspective. Of course, we do adhere to the building code, etc., and all that stuff. Most importantly, I think there are 3 areas that we want to focus on apart from prevention. Of course, prevention comes first, and then we talk about detection, protection, and fighting, which is a norm that we use in terms of fire safety management, right? So, prevention perspective, I think there's a lot of education that goes into our staff. That's very, very important. Of course, when it comes to retirement homes, also the seniors are allowed to engage with us, converse with us about this. So we have certain programs, periodical training programs that we have put in place, awareness program, etc. We can discuss more, but broadly, I think we look at a fire with a pretty sharp lens. We want to make sure that, and I'm very happy to. I was looking, today to know that about 80% of the fire accidents are, or 80% due to electrical short circuit, actually underlines the fact that you need to have a great electrical, review, audit, periodical reviews, and certifications, etc., in place. And that's a very, very important thing that's come out. But yes, we focus on detection, protection, and fighting as a norm, which I can talk as we go along.
Thank you so much, Raj. I'll come back to you with questions, detailed questions. Let me turn it over to Arnab from who runs large hospitals. So, Arnab, your perspective.
Hi, good afternoon, and it's quite interesting to be here because I remember my previous discussion with Gopal and Cheryl as well. And typically, I think I must congratulate you for taking this entire subject, for showing your resilience, for taking this so seriously for over the last few years. So, congratulations to both of you and the entire group of the foundation. So, the subject itself is something which Gopal was insisting. Then, why don't you talk? I said we could have taken some subject matter expert who could have given some typical guidelines, and then he said, no, possibly you would be able to give the perspective. So, I thought it's in this way. When I started the career in this, one of the first thing my mentor said that if you think that anywhere you can do little cut short, you can try, but never ever get into the line of the fire safety into the cut short mode. That's how the introduction happened for me to this hospital business. So before we go to that direction, I had the space of hospital, Manipal Hospital, Whitefield cluster. So this consists of 2 hospitals. Typically, we manage into around 500 operating beds into 2 directions and two hospitals, and we have got 3 smaller sort of clinic, within this cluster. So essentially, we manage almost about 30-35% of the 40% of overall Bangalore business for Manipal. I would not say business, the part of the overall community care for Manipal Hospital. So this is something I think Manipal as a name we know all of us. We have around 9 hospitals here, and we are going to add quickly another 3 hospitals in next 8 to 9 months. So now the question is, it's a large hospital group, but what do we do within that large hospital? And the challenge what we normally face is we have hospitals of 600 bed size, and we do also have a hospital which is about 90-80 beds. And it has got a dimension of a structure which is 40 years old, which and we have got another structure of which is just newly built. So newly built. So the challenge is what remains important for all of us. How do we manage a sort of a care or a methodology is what we use, which is unique, not unique, which is similar to all other standardized across the hospital. And that's where we have realized that if we try to address this problem as an individual problem, then we are not going to get there at all. So we have created a seamless across the hospital an awareness program. And end of the day, as my mentor said, that this awareness we have to somewhere make it a top down. So if the leader is pretty much aware about it, if he's or she is sensitive about it, the whole organization is going to react in that manner. And that is why when we go ahead and start a hospital or we go ahead to have a monthly meeting update everywhere, we first talk about the safety as a subject and fire remains at the top of this. So that way, as an organization wise, everyone is pretty sensitive. And even if we talk to the entire Beyond Carlton team, we must remember there's an incident which we have almost observed in front of us, and some of our team members have been a part of that entire incident. So there are a lot of memories, a lot of concerns, a lot of situations that a lot of things which we don't forget at all. So that's one of the reason I think Gopal, Cheryl, we have connected more emotionally than
Yes.
that of professional, sort of a connect. So from there, I think since we have gone through a situation like this, the entire organization is quite sensitive about the whole thing. So I will keep it at that because
Yeah.
Raja's perspective, in terms of what do we do as a proactive manner, how do we react to the situation it happens. So more or less, that is pretty much most of the sensitive organization will do in a similar manner. But yes, as an organization, we feel more connected in this entire event because some of us have been as a evident. As seen it in front of their eyes. So
Yeah.
thank you
Thanks,
for
Arnab.
taking
And
this
what
forward.
and for the audience, I think what Arnab is specifically referring to is when the Carlton fire happened, it was actually very close to Manipal hospitals, and of course a lot of the people were treated in Manipal hospitals, and we're grateful for that. So Arnab, I think what Manipal hospitals did at that time was fantastic. So thanks for all that. So I think you brought up an important point about different kinds of buildings. So the next panelist, I think, has got expertise on that. So Sujayanti, over to you. She's an architect. She's spent a lot of years focused on healthcare facilities, building. So yeah, what is your perspective, Sujayanti? Overall, tell us a little bit about what you do and how you think about fire safety from a healthcare perspective.
So, first of all, thank you so much for making me a part of, this very esteemed panelists. Everybody else on this panel is on an everyday basis in the thick of things when it comes to healthcare. As an architect that is a healthcare-focused architect, I operate on the periphery of it. However, having worked just on healthcare buildings for 27 years, I am tied very emotionally to what an environment can do to either aid the well-being of patients or to actually get in the way of it. So from where I stand, and when I started my journey many moons ago, I was lucky enough to have mentors that kind of drilled a couple of things into me, that we are designing for a fragile population. We're not designing for a population that is ambulatory, that is able to take care of themselves, and that is able to look out for their own well-being. So we start at that point, is that you are designing for an environment that nobody really goes into willingly, but they are there because they absolutely have to be there. So therefore, failure of infrastructure is not an option. So where we can, while we as architects cannot contribute towards the medical component of it, definitely we are responsible for the environment in which, under the umbrella of which medical miracles happen every day. So that is, we take that responsibility very seriously. I think, so having done this for like 27 years now, I'm running, I am a co-founder at Ward 4, Healthcare Architects. So we basically spend our entire lives designing for healthcare, or for fragile populations. So that could stretch from anything from clinics to, of course, hospitals, senior living environments for, differently abled people, transition care. It can even go into the sectors of, children that may be struggling with certain disabilities. So our tagline is designing for fragility, basically. So I hope that that kind of encapsulates what we do on an everyday basis within our studio. So I go back very often to that, that mantra that was shared with me, is that, so failure of infrastructure in an environment such as this is absolutely not an option. And then we've kind of, as we've gone along the way and we've had so many interactions with terrific administrators, hospital management, doctors who have, you kind of feed off of their passion for taking care of when people are the most fragile. And we've imbibed that sense of zero tolerance for loss of life. And when you go into a hospital, really, you can't die because you got caught in a crossfire of fire and smoke inhalation. That's a complete infrastructure failure. If you look at it in a broad sense, and the failure can be caused on many levels, but in the broad sense, that's failure of infrastructure. The other thing I do question very often is, and this is my personal learning, is that, in any other building, I think evacuation is a very, it's a very viable discussion. But is that the case in a hospital? Can everybody be evacuated? Certainly not your patients who are on ventilators. Can you really evacuate your NICU babies? And I think that is where our difference kind of starts, in the dialogue that we have within India, and where, I've heard and seen dialogues in other parts of the world. I think that is something I would implore all hospital administrators to first ask: can we genuinely evacuate everybody? If that is not the case, then those that we cannot evacuate, is that an acceptable loss of life for us? So that is a question I would start with. And then the last thing that we kind of delve with when it comes to fire safety is, there are two things when a fire happens. There is fire and then there's smoke.
Yes.
Very rarely do people die directly caught in a fire.
True.
Most people die because of smoke inhalation. And that is a highly preventable, and controllable element, which then would aid for you not to have to evacuate your patients in the first place. So we can go into a little bit more details about it when we go further. But yeah, in terms of fire safety, this is something that we start off with within our studio when we design hospitals.
Thank you so much, Sujayanti, for those perspectives. Very interesting perspectives on, and you're absolutely right about the inhalation part. In most fatalities, it's actually the inhalation which causes it. Now, let me turn over to Dr. Lallu Joseph, the CMC Vellore, but also a very important role as the Secretary General of CAHO. So tell us a little bit about both and what your role is and your perspective on fire safety.
Yeah, thank you so much for having me. I truly appreciate the passion with which Beyond Carlton functions. I've witnessed a couple of programs of yours and truly appreciate you for being so passionate about what you're doing. Regarding my background, I work with the Christian Medical College Vellore, which is about 4,500 beds. And I also head the Fire and Life Safety Committee of the Christian Medical College Vellore. I will share with you my experiences because it's a very large institution, 125 years old, with almost 40 plus high-rise buildings. So that's the level to which we manage. We almost have a fire safety bigger than a Vellore district fire team in my hospital. So with regards to the consortium of accredited healthcare organizations, we are committed to quality, patient safety and accreditation in the country. I'm a principal assessor with the NABH and part of the technical committee of NABH as well. So when I said CAHO, our entire goal is patient safety. And we started in the year 2013. And fire and life safety has been an integral part of what we do. For me personally, I come from an engineering background into healthcare and now managing doctors and nurses. So when I came into the industry, I just couldn't believe as to what was happening. I became a principal assessor and went into one of the hospitals in Orissa to do an assessment. The first assessment there, and I asked in the dialysis department, listen, there's a fire here, what will you do? As immediate response, they said, we will call this number 300 and the fire safety team comes in and the extinguishers are brought in. I said, okay, fire is spreading, now what are you going to do? And the technologist there just gave me an answer that they will wait for the patients, the blood to go back into the dialysis machine. It's only 150 ml of blood connected to every dialysis machine, 13 beds and all machines were full. So I realized the vulnerability that we are facing because most mock drills are conducted in our car parks just because you want a paper and you want to show the SSS when they come that you're conducting mock drills. You're actually not doing mock drills in the clinical areas. And this is a very simple one where these are ambulant patients. All you need to do is to clamp the line, make them sit up. They don't have a syncope. They're ready to run out of the facility. So, that presence of mind was not there. They did not know what to do. And after a month, I realized there was a fire in a dialysis setup in Bhubaneswar, not in the same hospital, another hospital, and there were lives lost. That's when I started developing protocols. And when I came back here, started developing protocols for midpoint surgery. What is the role of a surgeon? What is the role of an anesthetist? What is the role of a scrub nurse, a circulating nurse? So many people involved. And too many is also a problem. And, brachytherapy patients who are connected to a nuclear, radioactive source. And you have several patients who are on life support machines, on ventilators. Do people really know how to evacuate? And that's where we started with our fire and life safety training program, specifically on evacuation protocols. Because most hospitals are very old, we can put up systems in place for the newer ones. Considering the life of older hospitals, what do we do with them? We really need to have systems, infrastructure, but apart from that, we also need training, awareness, and all that. So lots and lots of protocols have been developed, and I've also been part of the National Disaster Management Committee. I do go in for fire investigations. And I must tell you proudly that I run one of the only programs in India approved by the Health Sector Skill Council to train fire guards. It's a one-year program. The last year, we trained about 6 specific to healthcare, and all 6 are employed. This year, CMC has given about 7,000 rupees stipend per month for these candidates, young boys and girls picked up from the community, 10th and 12th standard, because hospital fire is not like a regular fire. Your fire department comes in, they do not know what to do with the evacuation, or a patient who's on a life support, how to evacuate them. So you need the internal capacity built. And that's where we have come into the picture. Today, we have 20 candidates who are getting trained. By March, they'll be out of the system. And they'll be available for other hospitals. So a lot of work is happening. Hospital industry is not easy at all. So we cannot blame healthcare for everything that happens. Lots of focus to be put on electrical safety. That is something that I've learned out of the experience. It is not the fire infrastructure, but it is the electrical safety. And that's something that's totally neglected. That's my point. And thank you so much for having me.
And thanks, Dr. Lallu. Great points, and I'll come back to you. But let me go to Raj now. And Raj, can you talk a little bit about your thinking? Because, and we'll talk about kites. I'm specifically talking about kites, where you're taking care of elderly patients, either post-surgery, they come and spend a month with you, or if it's palliative care, they spend with you, and dementia care, which is a completely different setup where you have separate centers for dementia care. So how do you think about safety and fire safety when it comes to elder patients? And as you set these up, what kind of, how did you go about it? Because it's one of, I mean, there are not too many in India, right? So you're one of the early people to do this. So how did you kind of think through this?
See, a couple of things, Gopal. I think we've also been learning over a period of time, and this field is also evolving, and it will evolve as everybody's been suggesting. Uh, so, as far as the setup of a facility is concerned, one good news is that we are not pretty large in size in terms of the facilities. It's much more smaller and compact as compared to what Arnab is running or what Sujayanti would have developed or Lallu is driving. Okay, so therefore these are compact facilities. I think. From a fire safety perspective, when we build these facilities, we try to make sure that some of the basic time-tested systems are in place, which is your smoke detectors and sprinklers, etc. But we also focus and pay special attention to one or two areas which might trigger some of these fires, which could be your DG areas as well as your kitchens, where we have full-fledged kitchen preparing food for all the staff over there. So these two areas we give additional importance to make sure that we don't store any inflammables, etc., and all that stuff. And we follow. We are accredited to QA. Recently, NABH has launched its accreditation for this sector. In fact, this sector was not even in the radar of NABH until recently, right? So we've gone ahead with QA for accreditation. But from a preparation perspective, when we set up the infrastructure, we focus on these items, which is your sprinklers, smoke detectors, and have your extinguishers, etc., in place. But number two, the most important is the frequent training program. We take that very seriously. We have I'm sure some of the leading institutions will focus on, anybody from healthcare will know that the importance of quality function, right? So we do have a very active quality function, which also focuses, in our case, in terms of fire safety purposes. So we have a fire safety consultant. Whenever we set up a new facility, they come, they inspect, they train and coach the people, but this code red practice of monthly basis is adhered to. And once in 3 months, we get an external agency to come and run this program for us. In fact, recently we collaborated with the fire department also to do a mock drill, actually, right? So what Lalu said is the right thing. When the fire department came, they didn't know how to handle the patients, especially in dementia center, etc., and all that stuff. So these are the ways in which we actually prepare ourselves. A couple of nuances. Bed-bound patients, how do you evacuate them? That's been because we obviously cannot use the lifts. Good news is our buildings are not extremely high-rise buildings, but at the same time, we also have standby wheelchairs which can be manually pushed down the stairs. That's something that we have invested in recently. We need to do more because I think the quantity, etc., and all that stuff has to be checked out. But broadly, these are some of the precautionary methods that we adopt in our centers, Gopal. But training is very important. Mock drills are conducted very seriously, but we don't move the live patients other than the active patients. We don't move the bed-bound patients, which is something that we'll have to go back and also look at closely.
Yeah. Thanks, Raj, for that. And I'm not just going to you. I had a couple of points for you. One, I mean, the Whitefield Hospital, I've been there a few times. It's one of the largest hospitals in Bangalore, so it gets pretty crowded and high traffic. So how do you even think of mock drill? Like what Dr. Lallu was saying is absolutely right. I mean, how do you even plan those properly? That's question number one. And secondly, as a hospital leader, are you thinking of newer technologies in terms of safety and fire safety? Is that something that you guys are thinking about?
So, Gopal, I mean, in terms of, there are 2, 3 challenges what we have as a large hospital chain. In terms of how do you manage the drills? One of the biggest problem in terms of the drills are there's a huge patient care disruption. Then another problem what we have, as we becoming more and more compact, we have got typical staff ratios, how we are managing the hospital. And the moment you take out the guys for the drills, that's a huge nightmare. And then another problem what I've noticed is, as I think we have been discussing that the layouts are very different than any other places. It's not a hotel, it's not a house, it's not a complex where Your ICU, the entire layout would be different than the wards. Each ward will be different than others. So these are the normally difficulties what we have. But what normally we try to do, what we have realized over a period of time is something that one is you do a scheduling in the entire hospital experience. What we understood, there are high days, there are low days. So normally we have realized that when you want to do the drills, you do the low days drills based on the low days. So, I mean, we have been doing it on the low days, and we see comparatively we have a better participation. The chaos is, the lesser. And what we do, another thing is we rotate the drill locations. I think that has helped in terms of taking the drills more inside the critical areas. Earlier, the drills are typically into the floor levels. You do it into the OPD is the easiest, then go to the ward. You never touch the ICU areas or something. So that is another thing what we thought or what we have observed has been a little better. And in terms of another thing, what we have done, every drills, we have created a team of observers who come down, who keeps on writing in the overall observations, and we keep a huge debriefing session after that. And we ensure that next time, at least the amount of debriefing or the amount which has been a point which is located during these evacuations are lesser during the next time. So we have also created a policy where this ambulatory patients or the critical area patients, we have created a separate area. We have learned it over a period of time. Possibly we are learning even more. We are going to learn more, but we have created a separate area where cognitive challenge patients or someone who are very elderly, who are into life support. Yes, the NICU babies are still a concern, but we have tried doing a ventilator, with a mobile ventilators to move a patient, and we have tried. Yes, it's always a challenge when you do a drill and where you are into an actual situation. These are two different matters altogether. But yes, we are putting up our efforts. Most of the big hospitals are much more advanced in terms of these drills in actual and to manage the situation as a whole. Secondly, when you talk about the technology part, I think most of the hospital today would have a BMS. We have spoken about two things. One is a fire, and the other is the smoke. I think historically the smoke has created more mayhem than the fire itself.
Right, right. Like Sujayanti was saying. And
Yes,
BMS, just for the audience, is the building management system, right? That's what you're talking
building
about.
management system.
Yeah.
So we have somewhere, most of the hospital, we have done a integrated BMS. So the first response in terms of the BMS is it would be able to give you a direct monitor. It would be monitoring, on a live, 24/7, and it would be able to give you a feed on an immediate basis in case of if there is a detection. And the third thing, which is most important in case of a fire, there are two things which creates the biggest hazard in the fire. One is your AC, and second is your oxygen. I mean, I think Gopal has mentioned about that oxygen part. But even AC is something which is creates a huge role in the hospital. And unfortunately, fortunately, we are into the system where the entire hospital is in centralized AC. We are no more having a ward which is not AC. So what we have created the moment we identified any of the issues in our building management system, the HVAC is being automatically shut in that area. So this level of automation is being so far has been almost in not almost in all the hospitals has got a system where if you identify a smoke or a fire, the HVAC in that particular area would be diffused. And because of that, a large amount of catastrophe can be avoided, is something which I think which is beyond an automatic sprinkler or a fire alarm system, which is being done. Secondly, so which often in last 2 to 3 years, Gopal, and for others, there are a lot of vendors who have come. As someone has mentioned that more than anything else, the electrical equipments have created more issues, or the number of fire incidents what we have noticed has have gone through the electrical component. So there are vendors, there are high end equipment which has come today it can go through your all joints and old joints, entire your electrical system. They go through a thorough audit, and they give you a reporting. So we have made it almost mandated in, not almost mandated in all the hospitals to go ahead and do this audit. This is centrally monitored, and this audit has, audit reports are actions on an immediate basis. So what happens in that case? Possibly the chances of electrical fires being, almost reduced, or I hope it is eliminated completely. And the report, if it comes for change of some of the equipment, anything, so which is done immediate basis. So that is, I think that is one which will help a lot. Plus, recently, Gopal, there are a lot of companies who are coming with a smart sensors, which is beyond EMS. So you put a lot of smart sensors into very critical areas, and you detect it much faster than, even your BMS system does. So earlier detection is way better than, creating the action
Yeah.
force team, and that way I think that has become much more better than earlier days. And even today, all of your your own team and the vendor will work on the mobile applications. So you would, in case of anything, rather than waiting for a code red, you would get. I'm sure people are aware of the code red who are not. So it is basically, if you observe an incident of fire, immediately the concerned team or quick response team gets a call. So this mobile application, before it gets gets generated, they get the news. So this is something which is a super help, and something which is really encouraging for all the hospital operators. So I
Great.
think that quickly, something
Yeah.
which comes to my mind.
Thanks for that, Arnab. Sujayanti, I'll come to you, but I had a question for Dr. Lallu. Um, as a patient advocate, I mean, what do you think patients and caregivers, what do you recommend that they should do when they're going for, visiting hospitals or healthcare? Any suggestions for them? What do you think they should be looking at?
Yeah, certainly. Patients have a very large role in taking care of themselves. Now, we talk about patient engagement in a big way. WHO's World Patient Safety Day theme the previous year was on engaging patients for patient safety. So if you are an engaged patient, then you know exactly how to take care of yourself. Now, I had an eye surgery, and the only thing that I was concerned about was the surgical site marking. I didn't want my other eye to be operated upon. Because I was an engaged patient, I asked the right questions to my clinician, my surgeon. I was only worried whether the surgical site marking was done properly. I would have never allowed the surgeon to make a mistake on my eye. So that's the engagement that is required. When we go into a hotel, the first thing we look out for is the fire exit, or at least you are here and you know exactly, okay, this is the nearest step. This is where I need to go. So at least to that level of awareness, I think patients should know exactly where they are, because hospital is a very complex establishment. It is not easy at all. I think it's one of the most difficult places to manage. I'm married to a neurosurgeon who always said that managing brain surgery is the most difficult thing till he got into administration. The day he got into administration, he said, this is the most difficult thing. I can do a number of brain surgeries. So it's highly complex, too labor intensive. For managing one patient, you'll have 10 people. So if you have a 100-bedded facility, you can easily expect about 300 plus healthcare workers there. And imagine the number of relatives and others who are coming in. So as a patient, I think the first responsibility is to know where you are, the nearest exit, and also to know if that building, I would say go one step higher, is actually whether it has the approval, the fire safety compliance or not. I think it should eventually become the responsibility of the hospitals also to display, saying that this is a licensed facility. If not, at least to say this is audited every year by a third party, and we are compliant on basic fire and life safety requirements. So these kind of things, if the patients start asking smart questions, administrators like us will fall in line. So it's extremely important that patients are aware of where they are, ask smart questions, and also understand it's their responsibility also not to depend on everybody else in the hospital to evacuate them and things like that. Another important thing is not to have too many relatives. If you look at the Dindigul incident that happened, it was the patients who died, it was the relatives
Yeah.
Imagine
In the elevator, right? In the lift.
exactly.
Yeah.
And the automatic rescue device did not function. And when you are a healthcare provider, all you are concerned about is probably the patients. And they have done the right thing by evacuating all the patients. None of the patients have actually lost their lives. But it is the relatives who got into the lift, who got stuck there. So therefore, minimize the number of relatives who come into the setting. It's already a hazardous place. Why add on to the hazard? So be a responsible citizen. Do not get your entire village coming to the hospital to see how you are doing. So these are the two things that I would say. I'm being a little rude, but
no, I think those are fantastic points. Thanks for that. And I'll open it to the open it up to the audience for the last few minutes. But before that, one quick question for Sujayanti. Any advice on one of the things that we did, for example, Sujayanti, Beyond Carlton worked on in Bangalore was Bangalore City Blueprint. What should Bangalore City look for the next 5 years in terms of fire safety? And one of the things that pointed out there was NABH. I mean, the National Building Code is for new buildings after whatever 2016, right? But old buildings, whether it's the reset, there are lots of issues, right? How do you think about it? So we had actually suggested that there should be some retrofitting guidelines and things like that. Any thoughts that you have? Because we have a lot of hospital facilities which are old in this country, right? So what is your advice or any thoughts that you have in this thing on older buildings?
Okay, so this is probably the trickiest of it all. So there's three types of buildings that we end up working with. One is, of course, greenfield, which is the easiest thing to do things right from the start, correctly from the start. The second part of it is existing building, like Dr. Lallu Joseph is very much a part of, which is extremely tricky because there's a lot of existing circumstances that may or may not be documented, well documented for us to go back. The most dangerous place in these hospitals are above the plenum. So above your ceiling is where a lot of these hidden dangers tend to lurk, and neglected parts of it lurk. And the third part of it is actually a little bit like where Arnab's sitting today, is buildings that were never meant to be healthcare buildings that got converted to healthcare buildings. So there's three different degrees of, investigation, if you wish, that needs to happen on that front. Now, I'm going to set greenfield aside because that's the easiest of it all. If I were to tackle a little bit like Manipal Whitefield, at which I am a frequent patient over there, so, they did a lot of things right. For example, one of the NBC codes over there, one of the things that NBC says is that in a hospital, all staircases need to be 2 meters wide. And they actually took the time to break it down and make sure that it is compliant. So they were not necessarily, they didn't say, well, we have to start tomorrow. They said, we are going to be compliant and then we are going to start. So there are things like that. There are things like egress. What is the width of your egress? The width of the egress comes from, basic concepts like 2 of your beds should be able to ply between different parts of the building without having to cause an impediment on each other. The egress needs to be 2 hour fire rated. You have to look at those fire rating things that can be that need to be addressed. So all of those things, a lot of things, I think Manipal did right. In terms of Manipal has it right in terms of the building code over there. The trickiest one is where Dr. Lallu is sitting. So when we do have hospitals like this that come to us, well, they typically come to us when we are looking at, let's say, an overhaul of the master plan, of the existing master plan. That means when hospitals like this have been around for 25, 30, 40, 50 years, there's a lot of redundancies that get built into hospitals as large and as accomplished as CMC. So we get an opportunity at that point of time to evaluate 2 broad things. One is look at the utilization of spaces. More than not, you have a lot of redundancies that kind of come into play, where you have more space assigned to OPD than that is required, less to, let's say, phlebotomy, which is impacting the TAD, or how it is located. How is the whole flow located? So we get to evaluate that. And then what we put together at that point of time is a phasing plan, which means this is what you do first. Because the tricky thing about renovating or redoing or relooking at any operational hospital is nothing can stop. No part of the hospital can stop, unlike other facilities again. So what we put together is a phasing plan, which then looks at integrating fire safeties protocols at that point of time. So when I say that, can you evacuate everybody? One of the things about looking at that means is that, can you buy time? Can you buy time? Can you cut off smoke from coming into the compartment? So NBC very much says that, 1,800 square meters is what a maximum a compartment can be. That means any floor plate, it doesn't matter if your floor plate is, 9,000 square feet. You should ideally divide it into two, so you can cut off the two zones from each other. You can move patients into the safer zone and then buy time to either evacuate them or for the fire personnel to kind of step in. So there's a lot of these. You look at assemblies, you look at, the doors, are they smoke compartmentalized? Is the assemblies airtight? Are the ratings of the walls 2 hours? And there's a lot of things you can do retrofit. And it's a long it's a long process for an existing hospital to get to that point. But there are priorities that can be set in place, and it can be done. Of course, I'm going to say that infrastructure can have the biggest impact doing things right in the greenfield stage, but fire compliance and training is number one in an existing hospital. Because you will not catch everything that's not working in an existing hospital.
Sure, thanks. I'll just open it up. Thanks for those very, very critical points. I'll just open it up to a couple of questions. Dr. Lallu, you had your hand up. Were you wanting to say something? Go ahead.
No, I mean, I just wanted to mention that, as time passes and as complexities increase, what we are noticing is that the newer buildings are the ones that are most prone for problems. The ones that were built earlier at least did not have the air conditioning ducts and all your false ceiling and other things. And it's completely ventilated.
Yes.
And large corridors, wide corridors, evacuation is not a problem, G+1 or 2. Whereas the newer ones, without following the NBC code, is a huge problem. Less staircase width and corridor width, everything is a huge problem. That's the understanding. Having assessed 200 plus hospitals, I have come to the conclusion that it's safer being in an old hospital than a newer one, or at least a middle-aged one. That's sorry.
I'm just going to add to that, Dr. Lallu. I think you hit the nail on the head. The construction materials we used 50 years back were far more fire resistant than what we do today. So there's a lot of backfilling we have to do in order to compensate for quick construction.
Absolutely.
Very interesting perspective. Thanks for that. Anybody wants to ask a question, please go ahead. There are a couple of questions in the chat. But yeah, FES me. I know you're on the thing. Why don't you go ahead and ask a question? Just unmute yourself. Yeah.
No questions, actually. I'm very pleased to see this discussion happening online. Very, very important. I know I've been watching Dr. Joseph over several years already, what they're doing with the organization, and I also spoke with Cheryl a few years ago. I was in India as well. We were certifying firefighters there in Bangalore several years ago. We were trying to meet, Sam, but of course scheduling was not possible. It was great to see that. Just to let you know, we're out of Kathmandu and Malaysia, and we are training in Asia. We certify fire inspectors and a PA standard. So anybody that wants that, we just finished doing one a few months ago in Bangalore, or excuse me, in Dhaka, Bangladesh, I should say. So in Taiwan. Now I'm in the Philippines for the next several months doing similar. So again, very, very pleased to see such a group talking about this very, very important topic. I mean, it's healthcare, but just even today we saw the fire that happened in Turkey with the
with the
the
resort.
hotel.
Yeah. Yeah.
Yes, I mean, so again, the enforcement is critical. You know, and we got to teach
Right.
people better enforcement. So,
Yeah.
great. Just
Thank
great
you
to
for
see this.
thanks for that comment. There was one question by Anirudh Kaushik. Anirudh, if you're still on the call, go ahead. You can, why don't you just read out, state your question? But otherwise, I can read it out for you. Basically, he wants to know if the fire drills are good enough, or do we need to have a frequent information exchange platform, which is better? Any suggestion, Dr. Lallu, you have any point on that?
Yeah, so let me tell you what the accreditation agencies have done wonders to this country, particularly the National Accreditation Board. At least there are some guidelines that have come into place. All new staff, particularly in accredited hospitals like all of us, go through mandatory training program at induction and when they are shifting from one ward to the other or into the OR or ICU. And in my place, I do almost 86 drills a year, which means if you look at it every second or third day, every OR, we've got 14 OR complexes, and every OR complex, every month we have one drill happening. It's a real physical drill, not with the live patients, but we have all our students lying there as patients. And every ICU goes through this. Every healthcare worker at least once a year has to go through it mandatorily. And this is all captured as part of our platform as a continuing education for them. And without that, they just cannot go for their promotion. So there are things that have become extremely mandatory. So despite that, there are lots and lots of challenges. And that's where prevention, what Mr. Arnab talked about, and a lot of other things with regards to getting everybody involved, because attrition is also very high. So it's a basket without the bottom. So it's just training and people are leaving and leaving.
Yeah.
So it's continuous training, and that's the challenge for us, and which is where huge number of people are today involved in life safety in the hospitals.
Yeah.
The next time you see your bill, don't complain, because unless we have all these systems in place, we will not be able to take care of the patients.
Yeah. No, thanks for that. And I know we can go on. I think this is a great panel, but we've almost come to the end of our session. In fact, I've gone a couple of minutes past. I request Cheryl to kind of, say a few words and conclude the panelists. Go ahead, Cheryl.
Yeah.
Cheryl is the CEO of Beyond Carlton. Go ahead, Cheryl.
I'd really like to thank everyone who joined in this evening. We did it fairly quickly. I mean, Gopal is the mastermind of this session, and it's great to take vulnerable occupancies as important, and hospitals certainly are of great concern to Beyond Carlton. What are we doing in there and how are we doing it? And I think we've got great perspectives, from geriatry to pediatric to administration, and also from a patient advocacy, patient side point of view. I had just a few questions because I think this is such a powerful, well thought through discussion. Thanks for anchoring this, Gopal, very efficiently taken us through quickly and bringing the salient points up there. Just to sort of see whether we can find some aspects of collaboration and taking it forward. So my questions were like, things like, I remember when I spoke with you, Arnab, there were things we spoke about a checklist, and I think that's something that Dr. Lallu, you might also have. Is there something we can sort of, broadcast in a way, like as simple things, simple starters? Because we know we all struggle, like Beyond Carlton does a lot of work on the residential fire safety, and we struggle on the compliance because it looks like a longer story. But but at the same time, we look at how can we somewhat, begin to de-risk our lives from fire. So is there some kind of a checklist sort of system that you could share? I even like the idea of the fire guards that, it can be something that we replicate. I know you're doing work on the patient safety side. It would be a great day if hospitals were able to publish that we are fire safe or here's our compliance. That would be a great day as well. So I mean, these are the points. If there's some responses, it would be great to end on a note of some futures for fire safety.
So maybe we should hear from everyone as a final comments in response to Cheryl's questions. Dr. Lallu, you want to go first, and then we can round robin.
Thank you so much for that. So certainly we have a very, very robust and an elaborate checklist available. We have an agency that is doing third-party fire audits, and they are NABCB accredited. we have a platform which is available for hospitals to do self-assessment. That's not chargeable at all. They can use the checklist and do self-assessment. Beyond that, if they want to do a third party, then they can empanel and kind of get their facility third-party audited. So that checklist is available. I am happy to share the details of that. That's point number one. Point number two, as part of advocacy, we are also advocating to the patients that, ask smart questions. And one of which certainly is going to be this, whether the hospital facility is licensed, or do you have some kind of a third party that is conducted, electrical safety audited. These are smart questions that patients must be asking. So that also will be coming up. Cheryl, sorry, what is the third question that you put up?
The fire guards, I said,
Yes.
if that can be replicated,
Yes,
because I think that's a
certainly.
very smart
Yeah.
thing that you're doing.
So that is the Health Sector Skill Council approved course. So I had submitted that as a national QPNOS. So that is available and any hospital can start that. I've got the entire curriculum with me and I'm happy to set it up in any hospital if they wish to do that as part of their CSR, because this gives employment to several people. They are employed as security guards and additionally as fire guards at the hospital. We cannot depend on the external fire services if something happens in our hospitals. And these are extremely good initiatives, and I think every hospital must do that. I'm happy to set it up in any hospital and provide information.
No, that's great. In fact, that's something that Beyond Carlton can get some CSR funding also for that. So we can talk about that separately. Thank you so much for that. Raj, over to you. Any last words that you have, any comments?
I think wonderful contributions from everybody who participated, and Gopal and team and Cheryl, you've been doing a great job. We'll also like to learn from you and from everybody. From our perspective, whether it's pediatric or geriatric, I think, or it's a step-down care center, fire safety is equally important as much as what is done in an hospital. As Sujayanti said, greenfield projects are much more easier to handle in terms of designing and executing. The old properties come with the challenge, and of course, the other element of governmental nepotism and other things that comes in where buildings are sanctioned and approved, which continues to pose the challenge. But at the end of the day, service providers are responsible for every patient who comes in. I think fire, when it happens, God forbid, it's the people at the ground level who have to act immediately. So therefore, staff being very well trained and making sure the facilities to a large extent ready to meet if at all there is any exigency is the core focus from our perspective. We will continue to work, and probably if there's anything that we can work with you all, please let us know.
Great. Thank you so much, Raj. Arnab, over to you. Last words.
Yeah, thanks, Gopal, and thank you, everyone. In fact, it was quite enriching discussion. Another thing, any point of time, this is not something which we can put it across, stating that we are fire compliant. I think it's a constant learning, and we need to always, get a lot of inputs from a lot of people. We keep learning from the incidents. And that's where I think we should ideally try and get our technology up so that even if it is an old building, there are a lot of technology nowadays which is coming in, which can prevent a lot. Having said that, there are always concerns. Dr. Lallu will be definitely agreeing to me. There are fundings which are limited sometime, but what initiative Dr. Lallu said is something which is really thought-provoking. We do have a fire guard, we do have a fire officer, but somewhere if you can really create a program around it where you can contribute, across the hospitals, or because Bangalore is really having we do not have enough number of people who can contribute. So it's a good idea. We will get in touch, and if Gopal, if you can organize something where you can create a panel of people or pool of people who can contribute, I think a lot of hospitals will be happy to take them. And that's a serious input for all of us. But otherwise, great to know all of you. And Cheryl, thanks a lot for taking this up and keep pushing this subject beyond the limits of everyone. All the best. Thank you very much.
Thanks, Arnab. And final words to Sujayanti.
Yeah, so we have checklists ready with us when we go to evaluate existing hospitals or when we are designing new hospitals. I think one of the things where we can contribute is, in a very succinct manner, provide the check boxes that you need to hit if you're going to be fire compliant at all, whether it's in a new building, whether it's an existing facility, or whether it's a operating facility altogether. We also have a lot of vendors that we work with, where there are products that they like Mr. Arnab suggested. Lot of products that are focused on mitigating fire incidents. and I'm happy to share that list as well. I really appreciate y'all for putting this together, because this is something that somehow kind of falls by the wayside sometimes, and not, I mean, given the number of fires and hospital administrator, not literally, but metaphorically have to deal with on an everyday basis. I do not envy Arnab or Lallu or Raj on any of this. I'm the one that's sitting at the prettiest end of it. So I deeply respect their positions. But if there's anything, any endeavor where we can contribute with technicalities, basically, of the infrastructure itself, we are very happy to participate in that. Thank you for the opportunity for me to yet again learn.
Yeah. No, thank you so much, the panelists, Raj, Arnab, Sujayanti, and Dr. Lallu, for spending your precious time with us. We have recorded the session, so we're going to publicize all the key points that we learned from here. So thank you very much, and thanks for the audience who participated, and good interactions and great inputs. Thank you, everyone. Really glad to have done this session. I just want to end with one thing. Our memorial, the annual memorial lecture, a memorial event of Beyond Carlton is coming up on 22nd February. I would request all of you to attend. It is at 6 p.m. at St. Joseph's Boys School in Bangalore. So we will send you all an invite. We'd request all of you to come and attend. And we'll be doing a lot of similar sessions where we're trying to bring in more awareness that in different areas that we can bring about on fire safety. So thank you very much, all of you. And